So, very good morning to all. We were discussing about the management of the stroke till now. With the last we saw about the airway and the ventilation, in which we already talked about the supplemental oxygen part also. Moving forward to volume status. Now, volume here means the volume of the blood specifically. So, hypovolemia, decrease in amount of blood, has been associated with worse outcome and increased mortality in acute ischemic stroke. Naturally, if the amount of blood in the body decreases, there will be less blood to circulate and less blood reaching already to the brain. So, it will lead to more and more neurological signs and symptoms. So, chances of death are much more higher. Isotonic saline, that is normal saline at 0.9% should be used for volume repletion and maintenance. Typically 3 liters per day is given. Now, much more important, normal saline is nothing else but a solution, watery solution in which there is NaCl, yes, sodium chloride. So that is normal saline, that is isotonic. Do not give hypotonic, decrease or less amount of iron solution, that is dextrose in water, because it will lead to more amount of less amount of ions and more amount of glucose, which is not desirable at this point. We need ions and glucose in the same amount. That is why always give for isotonic saline, that is the ions in the blood, the same ion should be in the external source that you are supplying the body, as it may worsen the cerebral edema. Dextrose leads to increase in the cerebral edema. Temperature. Fever is the setting of acute stroke associated with poor outcome, possibly due to three reasons. There are three reasons why increased temperature or fever is responsible for deterioration in the condition of the patient. First is increased metabolic demands. At higher temperature, more and more enzymes work. More and more enzymes work, that is, more and more metabolism will occur. More and more metabolism will lead to more and more waste production. Yes. So this is the first reason. Second, enhanced release of neurotransmitter. If neurotransmitters are released more and more, there are chances that it will lead to increased amount of transfer of activities from the area, from the affected area to the nearby regions. And yes, because of this, there is chance that the damage that has already happened in local area will lead to generalized damage to the whole brain. Third, increase free radical production. You might have learnt about the theories of aging, in which radical theory is one of them. So if free radicals are more and more formation is there, that will lead to damage in the nearby areas. Yes, the free radicals that are produced damage not just one or two, but many molecules, many cells nearby the affected area. So, or three reasons. First is metabolic demands. Enzymes will be activated. Because of the enzyme activation, it will lead to increase amount of metabolism, and this metabolism will lead to increase amount of waste production. Second, release of neurotransmitters. Excessive amount of neurotransmitters will lead to nearby area damage. The same thing applies for the free radical production. Free radicals are nothing but waste products formed which cannot be stabilized. Say for example O3. Yes, in body O3 is formed, O3 minus specifically, it is formed, and this can transfer from one cell to another by damaging them. So this is an example of free radical production. Lowering acutely elevated body temperature might improve the prognosis in stroke patients. So keeping the patient at normal level, say for example 37.5 degrees Celsius, that is our normal body temperature. Keeping it in patients in those temperature will help in better prognosis in stroke. Antipyretic agents like, first of all, paracetamol, that is also indicated, and acetaminophen and other cooling devices might also be used. Yes, now comes the drugs. So you are supposed to read the drugs, you are supposed to remember the drugs. Acetaminophen and paracetamol, both are antipyretic agents. Relevant antibiotics might also be used if the temperature is increased because of the infection. जो infection हो, immediately there are less chances, but later on chronically, yes, you will see there are infections, and because of the infections you might need to provide antibiotics along with the antipyretic agents. Thrombolysis. So thrombolysis within first 4 to 5 hours is common. Excuse me. In 3 to 15% patient, you will be able to see such things. Yes, thrombolysis. RTPA at Altiplase and streptokinase. These are the agents, these are the enzymes that are need to be administered in the body for the purpose of thrombolysis. So first you will assess the patient. In assessment past, first you have to see the CT scan is normal. Second, blood pressure is less than 180 and 100, that is 180 systolic and 100 diastolic of mmHg. No bleeding tendency. These three should be prerequisite. આ ત્રણ હોવા જ જોઈએ. પછી જ તમે thrombolytic agents you will introduce in the body. RTPA is nothing but tissue plasminogen activator. Yeah. Dose 0.9 milligram per kg weight of the body. Yes. So say for example, an individual is of 100 kilos. So for that 90 milligram is the required dose. Yes. Maximum is the 90. 10% bolus, rest 60% by infusion. So as much as possible you try to provide along with the food 10% and rest 60 rest you can give 90% you can give in 60 minutes by infusion, that is IV line directly. There are chances because of thrombolytic agents in the body, because of the three enzymes you are introducing in the body, intracranial hemorrhage is possible, but chances are only 6%. Reduced morbidity by 30%. So if you provide it on time, the chances of patient surviving are much more higher. This was about thrombolysis. Why is thrombolysis needed? Because if there is hemorrhagic stroke, there will be chances of a thrombus formation or a thrombus clotting the blood vessel, clogging the blood vessel. એક thrombus form થયું હશે એના લીધે blood supply આગળની hamper થઈ હશે. So it is immediately needed that you apply these agents that will be responsible to break down this thrombus. Thrombolysis, lysis is breakdown. Yes, so ಈ thrombus ને break down કરવા માટે it is more important that you provide these agents. Blood pressure. Now we also talk about the risk factors. Risk factors માં આપણે જોયું તો blood pressure is one of an important indicator or important risk factor which is modifiable. Reduction of blood pressure in acute stroke phase is controversial. Why it is controversial? If you decrease the amount of blood pressure, જો તમે initially blood pressure decrease કરવા માંડો, then there are chances that you are causing again same thing જે stroke માં થાય છે, that is decreasing the amount of blood reaching the brain. Brain ને blood મળતું નથી, એમાં તમે blood pressure ઓછું કરી દો તો વધારેમાં વધારે ઓછું થઈ જશે. So it will be deteriorating the condition. BP should be kept within higher normal limits since low blood pressure could precipitate perfusion failure. Yes, normal જે oxygen and nutrition મળવું જોઈએ brain ને એટલું પણ નહીં મળે if you are starting to decrease the blood pressure. When treatment is indicated, cautious lowering of blood pressure by approximately 50% during the first 24 hours after stroke onset is suggested. So within 24 hours, you should decrease only 15%. Yes, the physician will only decrease 15% when the patient is administered for decreasing the blood pressure. Systolic blood pressure, as we described, if it is more than 185 and diastolic, if it is more than 110, it is a contraindication for thrombolysis. Because at that time, if you provide thrombolysis, there are chances of what we already saw, intracranial hemorrhage. Yes, so high blood pressure with thrombolytic agents will cause intracranial hemorrhage. So for that reason, if it is more than 185 and this is more than 110 diastolic, then it is a contraindication for thrombolysis. You should not go for it. Wait for the patient's blood pressure to reach the higher normal limits. These are the higher normal limits. 185 is the higher normal limit for systolic. 110 is diastolic. Once it reaches that 185, 110, then you can administer again the thrombolytic agents. By blood pressure management, you are targeting three things. First, reducing the formation of brain edema. Yes, the intracranial pressure that was increased, that can be managed by blood pressure. Second, lessening the hemorrhagic and transformation. So wherever a part of hemorrhage is there, if you maintain the blood pressure, that will not be transformed or the size of the hemorrhage will not increase. If the blood pressure is higher, there are chances that more and more damage will happen and the hemorrhagic size or hemorrhagic part involvement will be more. And third is preventing early recurrent stroke. So second attack or the second brain stroke can be prevented by blood pressure management. These are the three main things why we want to maintain the blood pressure. Reducing formation of brain edema. Second, lessening the hemorrhagic transformation. And third, preventing early recurrent strokes. However, Aggressive treatment of blood pressure may reduce the perfusion pressure of the to the ischemic areas of the brain, as we already described. જે part already affected છે ત્યારમે blood pressure aggressively decrease કરી દો તો જે affected area છે એને પાછું blood જ નહીં મળે. જો પાછું blood જ નહીં મળે, then there is no meaning of providing the treatment. You are deteriorating the patient. Yes. In majority of patients, decline in blood pressure occurs within the first few hours of stroke, even without any treatment. So even without any treatment, you don't give treatment in first few hours, then also the blood pressure, if it is very high, then it comes to normal. The body itself will maintain and bring the normal blood pressure back. Systolic if more than 220 or diastolic more than 121 to 140. Treat with a goal of 10 to 15% reduction in the blood pressure using two main agents, labetalol, that is given again intravenously over 1 to 2 minutes, and nicardipine infusion, that is titrated up to 0.25 mg per hour at 5 to 15 minutes interval. Yes, you need to remember both the things, labetalol, which is a beta blocker, and nicardipine, which is a calcium channel blocker. So labetalol 10 to 20 milligram intravenously. You need to remember the dosage. Nicardipine infusion 5 mg per hour. You can remember this thing only. Yes, nicardipine infusion 5 mg per hour and labetalol 10 to 20 mm intravenously should be administered to monitor the blood pressure. So systolic if more than 220 and diastolic 121 to 140. At this time it is indicated that you provide these agents to decrease the amount of blood pressure, only 10 to 15% reduction in blood pressure. Yes, which is indicated. More than this, you are harming the patient, and the patient will not receive sufficient amount of blood again, that you are causing the deterioration. Coming next to glycemic control, the amount of glucose in the blood. So hypoglycemia, that is, can cause focal neurological deficit mimicking stroke, and severe hypoglycemia alone can cause neuronal injury. Now we already know brain utilizes most of the carbohydrates and oxygen. Now if the brain is not getting enough amount of glucose and oxygen, it is example of a stroke. So hypoglycemia, that is decrease in amount of glucose in the blood, directly will lead to stroke. Yes, so it will mimic the symptoms of stroke. Check the blood sugar, rapidly correct the low serum glucose. Hypoglycemia, blood glucose less than 60 milligram of deciliter, should be treated in patients with acute ischemic stroke. The goal is to achieve normoglycemia. Yes, the normal level of glucose is to be achieved. That is our main role. We do not want to go for hyperglycemia. Yes, that is the reason we are not providing dextrose, as we already saw. Anticoagulants. Anticoagulation in acute ischemic stroke is not recommended for the treatment of stroke. If hemiplegia is dense, commence subcutaneous heparin 5000 units in 12 hours. So heparin, it is an anticoagulant agent. It is indicated only if you are sure about the hemiplegia. It is a confirmed sign that yes, hemiplegia is there. Maybe upper limb is more affected, lower limb is more affected, that is AC or MCA infarction will be there. But depending on that, if it is confirmed, then only you provide heparin, that is 5000 units in 12 hours. Low dose subcutaneous low molecular weight heparin, most preferable. Yes, simple heparin is never used nowadays. It is always low molecular weight heparin, or unfractioned heparin may be considered for prevention of DVT in patients with intracerebral hemorrhage after 4 days from the onset. What is DVT? Can anyone tell me what is DVT?
Deep vein thrombosis.
Yes. So what happens in deep vein thrombosis? શું થશે પેશન્ટને deep vein thrombosis માં? What will be the signs and symptoms? What is the pathology in deep vein thrombosis? We already discussed it in secondary changes or secondary affection because of stroke, secondary impairments. Because of continuous blood pooling in a specific region, that is in lower limbs, there will be formation of thrombus, and this thrombus can be dislodged and form a embolus. Because of formation of embolus, it can go to any part of the blood stream, blood flow, and come back to the heart. You can go back to the brain, in the pulmonary region, in the lungs, and because of this there will be various sign and symptom other diseases. It is in the brain, again it will cause stroke. In the heart it will cause cardiac arrest or myocardial ischemia. In the pulmonary it will cause the same part affected will be having less blood supply. Yes, so to prevent DVT, we provide low molecular weight heparin or unfractioned heparin, which is given after 4 days from the onset, not immediately. Anticoagulants are not given in acute ischemic strokes. It is always desirable after a specific period of time, especially after 4 days from the onset. Antiplatelet agents, aspirin, the base antiplatelet agent within 48 hours to reduce the risk of mortality or disability in ischemic stroke. Other antiplatelets like ambizicam and inhibitor cilostazol, phosphodiesterase, and type 3 inhibitors are all such examples. Yes, you need to remember 2 or 3 according to what you can remember. Antiplatelets contraindicated in hemorrhagic stroke. Once a hemorrhage is formed, then there is no need for platelet aggregation prevention. Antiplatelet, as the name suggests, it will prevent aggregation, that is combination of various platelets. So it will not form a clot, a thrombus will not be formed. Yes. In ischemic stroke, this is desirable. Why desirable? Because there is ischemia and there is part that is injured in the brain. Yes, but there is no hemorrhage formed. There is no aggregation. There is no thrombus formed. To prevent even this thrombus formation, antiplatelet agents are given. Yes. So for this reason, it is already desirable in ischemic stroke, but in hemorrhagic stroke already it is formed. So there is no reason. Then you can go for heparin administration, but not antiplatelet agents. Neuroprotective agents. Now there are specific vitamins that are responsible for maintaining the normal function of the nerves or to help prevent further injury to the nerves or the whole nervous tissue, you can say, not just the nerves, you can say also other tissues which are nervous tissues. Protect neurons from adverse milieu created by the biochemical changes triggered by the ischemia. So whatever changes are because of the ischemia, these agents will help prevent those. Examples: free radical scavengers, vitamin C, vitamin E, and encefibol, that is prinditinol, that is a beta blocker. These 3 agents are utmost important, as we talked about the free radicals. Yes, in the blood pressure, in the temperature. So free radical, if we want to prevent damage by the free radicals, these are the agents to be used: vitamin C and E and prinditinol, that is a beta blocker. All 3 can be used. These are the only effective ones we have found. At present, no pharmacological agent with putative neuroprotective action have demonstrated efficacy in improving outcome after ischemic stroke, and therefore other neuroprotective agents are not recommended. So only 3 agents are recommended: vitamin C, vitamin E, and prinditinol. These are the only neuroprotective agents that can help in ischemic stroke. We want to prevent the increase in temperature and also prevent the free radical damage to the brain tissue. That is why we are providing neuroprotective agents. Coming to medical complications of stroke. So medical complications of stroke have been reported in as high as 85% of the patients with stroke. Medical complications account for at least 50% of the mortality after the first week of stroke. The most common encountered complication related to immobility and infection. These are all what we have discussed about secondary impairments. Yes, not directly because of stroke. Stroke na lidhe kai જ નથી થતું, but stroke na lidhe patient bedridden છે, move નથી થઈ શકતું, and that is why there will be secondary impairments. Say for example contractures, say for example DVT, pressure sores, infections, osteoporosis, increased chances of fall, and because of this increased chances of fracture. All these are medical complications of stroke. However, most important cause of mortality, death in the early period following a stroke are related to cardiac, that is arrhythmias and myocardial infarction. Arrhythmias, change in the rhythm of the heart. Second, myocardial infarction. Myocardial, that is muscles of the heart. Infarction, not receiving enough amount of blood, and that leads to damage to the heart. Infection like pneumonia, urosepsis. Yes, infection utmost common is UTI, urinary tract infection, that is also termed as urosepsis, and pneumonia, that is pulmonary infection. Yes, venous thromboembolism, that is pulmonary embolus formation. If there is pulmonary embolus formation or pulmonary embolus is formed, it will clog a specific part of the lung and it will be hampering the ventilation and perfusion of the body. It leads to the myocardial infarction also by moving this embolus into other regions of the heart, and if it is in brain, it will again cause a second stroke. So these are the complications that you see a patient with stroke in hospitalization. For a physical therapist also this is important. When you are seeing IPD patients, they are already admitted in the hospital, and that time you are visiting the patient, you see for all these signs. If any of the sign is present, you should inform the staff, medical practitioner or the nursing staff that is possible to reach. Complications of immobility. Now, if the patient is not moving, deep vein thrombosis are there, pulmonary embolism. Deep vein thrombosis, as we already described, the patient is not moving the lower limbs, and because of this, there are chances that the patient will form thrombus in the lower limbs. Falls, there are increased chances of falls, and because of this, there will be fractures, as we already described. Pressure sores or ulceration. So, because the patient is not moving about or the patient is not changing the position, bony prominences, more specific, bony prominences of the body will be responsible or will be under pressure continuously, and because of this the skin starts to break down. The skin breaks down, then the superficial fascia, deep fascia, and later on even you can see the muscles being affected, and you can see the bone directly over from that area. So that is pressure sore, a sore or an ulcer formed by the pressure. Infection. Chest infection, aspiration, pneumonia are common. Urinary tract infections are also common, and other infections you can also see. Malnutrition, because there is dysphagia and dehydration. Dehydration, decrease in amount of body fluid, and dysphagia, difficulty in chewing and swallowing, as we have already described. Pain will also be there. There will be shoulder pain, that is subluxation in the paretic limb. We are also going to discuss one important condition, that is CRPS, complex regional pain syndrome. Yes, patients are prone to pain, shoulder pain specifically, because the head of the humerus is maintained in the glenoid fossa by specifically the muscles of the shoulder region and the ligaments. In paralysis, once the paralysis happens, the patient will not be able to, or the patient's muscles will be completely without tone, and because of this there are chances that the head of the humerus becomes subluxed, moves downwards, yes, specifically in the inferior direction, and because of this there are chances the nerve may be impinged, injured, and there are chances there will be shoulder pain. There may be also miscellaneous pain. In the initial stages, the patient will complain of headache without a known cause. That was the first early sign also. Musculoskeletal pain will also be there later on because of the tightness, because of the contracture, because of the immobility. Central pain stroke syndrome, as we have already described, when there is affection of the thalamus, thalamic pain, which is also central post-stroke pain. When thalamus is affected, as thalamus is the relay center, all the sensory and motor fibers, ascending and descending pathways are moving through the thalamus. Because of this, if any part of thalamus is affected and the nerve itself is being entrapped, the pathways are affected, that will lead to central post-stroke pain. Neuropsychiatric disturbances, that is in long term, chronically also, and even during the stay, you will be seeing such patients who become depressed, who are very anxious, and emotional incontinence will be there. Yes, we also talked about the pseudobulbar effect, immediate laughing or crying without any cause. Yes, अचानक ज patient हंसवा मंडे, रोवा मंडे, कोई cause विना. Anxiety, the patient is anxious at all times, already ready to be angry. And depression, if the patient is not able to cope up even in the acute stages, there will be depression. Acute confusional states, that is delirium, one of the levels of consciousness. Yes, the level of consciousness, unconscious, coma, completely conscious. Delirium is nothing else but a state of confusion. What is happening, what is not happening, the patient is not oriented mainly, that is delirium. Miscellaneous, say for example cardiac complications, as we already described, myocardial ischemia, arrhythmia, gastrointestinal bleeding, constipation, arthritis, sleep apnea, nutritional deficiencies. Most of the patients with stroke, the normal age what we will describe will be around 35 to 65 years of age, or 45 to 65 is more specific. So you can see the age that is affected. Patients of stroke, utmost common in this age. Chances of getting a stroke is 35 to 65 years of age. Now in this age, there are other bodily changes already. The patient is already moved to geriatric age, old age. And because of this, there are other complications, say constipation, arthritis, sleep apnea, nutritional deficiencies. All will lead to increase in the complications, that is in the patients with stroke. Deep vein thrombosis and pulmonary embolism. The highest incidence occurs between the 2nd and 7th day post-stroke. Yes. After the patient has been admitted to the hospital, from the 2nd to the 7th day, that is within a week, there are chances the patient will form deep vein thrombosis, because initially only there are chances the patient will not have any assistance in the movement. Movement કોઈ કરશે નહીં, એના લીધે blood clot થશે, blood એકની એક જગ્યાએ રહેશે, and because of this there is formation of thrombus. Estimate of early death attribute to PE range from 13 degree to 25 degree. So because of pulmonary embolism, directly 13 to 25 degree patient die of. Occur most frequently between the 2nd and 4th week. So once the deep vein thrombosis is formed, it will clog out. This thrombus is converted to embolus. This embolus goes to the lungs, and because of this there will be death. So pehla to form thase within a week, and from 2nd to 4th week there are chances the patient will die because of the pulmonary embolism. Measures to prevent DVT should be routine for all patients with ischemic stroke administered to the hospital. So to prevent DVT is the first aim of a medical practitioner, so that the patient can at least survive and will not die because of pulmonary embolism. So what can be done? What can be done for prophylaxis? Prophylaxis means prevention. Tight fitting knee or thigh high anti-embolic stockings reduce venous stasis in the leg. So these are nothing else but like a sock. They are to be worn in both lower limbs. They apply pressure over that part. Because of the pressure, there is continuous movement of the blood. Pneumatic compression devices can be applied to lower extremities of non-ambulatory patients. So say for example, lower limbs are more affected compared to upper limbs in the ACS stroke. Yes. So in such patients, you will apply a specific compressive device. So this is also a type of sock. You will tie it on the leg, and then you will on the device. What will the device do? It will provide contraction and relaxation of the muscles externally. Yes, it will contract the leg, relax the leg, contract and relax. Because of this, pumping action will be there and the blood will move to the heart again. Use of low intensity anticoagulation for DVT prophylaxis is recommended for all immobilized patients with stroke, but again to be given with precautions that we have already seen with anticoagulants. In patient with primary intracerebral hemorrhage, initiation of anticoagulation for DVT prophylaxis is delayed by 3 to 4 days. So as we talked in anticoagulants also, if it is an hemorrhage and if the hemorrhage is not resolved, there is no meaning of giving a anticoagulant agent. So if anticoagulant agents you are providing, it should be specifically for ischemic stroke. For hemorrhagic, it can be in the later part also, it can be delayed. Early mobilization, important part for physical therapist. Whenever you go to the patient to see them, you always mobilize their ankle joint. When you mobilize the ankle joint, then only there are chances the DVT will not be formed. Mechanical compressive devices. Mechanical compressive devices are the same devices like what we talk pneumatic compression. So pneumatic compressions are automatic. Here, these are mechanical. So you can provide socks which can directly put pressure over the leg and will not allow the blood to pool in the lower limbs. And because of this, there will be less chances of formation of DVT. Anti-embolic stockings, sequential pneumatic compressive devices, the same thing that we already described. Subcutaneous unfractioned heparin. Yes, so again, our role of heparin plays a very important role in DVT prophylaxis. So initially also it gets started. Low molecular weight heparin, both we have seen in anticoagulants. Patient with embolic infarction should not be treated with heparin or with any form of anticoagulant in the first 30 days. Yes, so as we already talked about, if there is formation of embolus, if the embolus is lead to directly formation of hemorrhagic stroke, then we should not be providing such patients for 30 days. See, such heparins or any other anticoagulant agents. It will hamper the condition, it will worsen the condition. Yes, and there are chances Because of this, there will be more and more ICH, that is intracranial hemorrhage, and the patient will die because of the complications. Coming to the last part that for today, that is malnutrition and aspiration. Malnutrition and aspiration. A preserved gag reflex may not indicate safety while swallowing. Yes, gag reflex, function of which cranial nerve? We have discussed this in assessment. Which cranial nerve is responsible for gag reflex? Yes, everyone. Are you with me or not? Gag reflex kaya cranial nerve control करे? Sensory part is mainly controlled by 10th cranial nerve. Vagus nerve is responsible for maintaining of gag reflex. Yes, in the checking part we have seen. Swallowing evaluation should be performed in all the patients with dysarthria, aphasia, or facial, buccal, or lingual weakness. Yes, dysarthria, difficulty in articulation, that is formation of speech. Aphasia, inability to swallow. Facial, buccal, lingual weakness, if there is any facial muscle weakness, if the patient is not able to form sentences, if the patient is not able to speak up, or even the tongue movements are not there or is sluggish, weak, that time you check for the first gag reflex, and later on you see the swallowing evaluation. Inability to swallow safely should precipitate early placement of a nasogastric tube. So nasogastric tube, say for example Ryle's tube, is indicated in such cases where you see the swallowing is not proper. If swallowing is not proper, you do not administer the food directly. In order to assure gastrointestinal access for nutrition and medication. Nutrition is at most important. Whenever you provide nutrition to the body, then only there are chances the patient will improvise. Yes, if you are not providing, you are just going it through the IV lines without checking the swallowing function, you are hampering the abilities of the patient. Patient swallow કરી પણ શકે છે પણ તમે check નથી કર્યું એટલે તમે આપી નથી શકતા. Because of your fault, the patient will suffer. Later on, there will be difficulties in swallowing because he or she is adapted to IV line nutrition. Infections. Okay, we'll keep it for next lecture and we'll complete in the next lecture. By that time, Sullivan, everyone must have the soft copy of Sullivan, and if you don't have, I'll forward it to the group. So once you have the soft copy, go through the chapter of stroke. In that, specifically, when you are scrolling down, there you will find a table with all the medications that are responsible for or that are to be administered in patients with stroke. So go through the table. We have afternoon lecture again, 1:15. So by that time, you will be thorough with all the medications. One table is given, and in that all the medications are mentioned. Yes. So we are discussing in detail. I'm explaining you the mechanism, why it is happening, why this is important, why it is not to be given, indication, contraindication, precaution, everything we are seeing. But in that table, you will be able to see all the names of the medications that are to be remembered by you. Yes. So in exam, whenever it is asked, you just need to write that table. But for your understanding, we are going this in detail. Once we are completing stroke, the pace will be higher. Yes, not in the assessment part or the clinical feature part, but the management part will be higher. Why? Because we are seeing each and every drug that is being used in detail in stroke. That is why it has taken so much time. After this, when we are seeing other conditions, it will be comparatively faster. Yes. Okay. Any doubts till now what we have discussed so far? Please let me know, yes or no, in the chat, everyone.
Sir,
Yes, yes.
meaning of delirium.
Delirium is a, you can say, confused state of mind. Initially, the patient will be in complete coma. Yes, after coming out of coma, patient will not be normal again. Yes, there will be a phase in which the patient will not be oriented to the surroundings. Kya છે, kaya person એની બાજુમાં છે, શું કરે છે એ હોસ્પિટલમાં. These all questions will be there. Yes, and that is a state of confusion. It is termed as delirium. Clear?
Yes, sir.
Okay. As we already described, we are going to see these things, consciousness level states in traumatic brain injury again. So at that time, we'll again revise and we'll let you know, I'll let you know in detail other types of consciousness or level of consciousness. Okay, fine. Purva, have you taken the attendance?
Yes, sir.
Okay, fine. So we'll keep it till here. We are again meeting in the afternoon and we'll complete stroke today itself. Yes, the medical management also. And again, I'll open the book. You open the book by that time. See for all the medications that are listed in the book, and you need to remember 2 or 3 example of all the classes. Say for example, it is antihypertensive, you should know 2 examples. Anticoagulants, you should know 2 examples. Antidepressant, you should know 2 examples. Just the name. If you don't remember the dosage, that is fine. Dosage I have taken in consideration in the presentation. It is not given in the book. Yes. Okay. So we'll keep it till here. We are again meeting in the afternoon. By that time, hope you have a good day. Be safe.
Thank you, sir.